everybody. I'm very glad to be amongst you today. I'm sure that you must have heard some very eminent speakers guiding you about the process of NABH, and I'm very thankful to Dr. Gagan Dudeja for giving me this opportunity. I am Dr. Samina Zamindar from Zamindar's Microsurgical Eye Center, Bangalore. I'm an NABH assessor, and I'm very honored to be a part of this All India Ophthalmic Society conference, though I'm not present amongst you. So today I'm going to talk to you about how to ace on the assessment day. I have divided my talk into 4 parts. The first part is prior to audit. What is something what you need to do with your team? You need to have a meeting with your team and tell them that this is a fact-finding exercise and not a fault-finding mission. So they need to relax, calm down, and look at the assessor as an expert who is going to come, travel from far away, spend the entire day with you, and teach you some important things to improve the quality and safety at your hospital. After this is done, you should also ensure that the emails for the assessor have written to you have to be read carefully, because there are a lot of points which the assessor would have written and asked for you in the email. One of them is details of what should be a part of the opening presentation. Now this opening presentation has to be submitted to you in a pen drive to the assessor to NABH. So please go through that correctly. There might be some other requests also from the assessor, like what were the non-compliances of the previous assessment. Please go through that. Something like the scope of services, the staff matrix, etc. So please read the mails and follow the mail instructions given in the mail. Prior to the audit day, there is one more information you should collect from the assessor. Is there what is their food preferences and if they have any food allergies. That would be really nice. This attention to detail is important here. You should also arrange for a room with privacy for the assessor or assessors to work. The second portion of my talk involves the day before the audit. The day before the audit, you should see that all the staff are requested to be present for the opening meeting as much as possible on time and in their proper uniforms. The hospital should be clean, neat and shining as usual. Moreover, there should be good Wi-Fi connection available so that at the last minute you're not struggling for the opening presentation or for the assessor's submission work. Now we come to the A part where what should be done when the assessor arrives at your doorstep. The first thing is to greet them and welcome them into your organization. Please do not worry about any bouquets or garlands or gifts. It's not required. The opening presentation should ideally be attended by all the core members of the team, core doctors, staff, very nicely dressed in their proper uniforms, and be present in the decorum of the meeting should be maintained. On the day of the audit, see that the assessor is accompanied by a knowledgeable staff, preferably somebody from your quality team who has good communication skills. And whenever you take the assessor to any station, the requisite registers and standard operating procedures should be available at that particular station. Whenever the assessor wants to interview a staff or a patient, requisite privacy should be given, and if you are allowing the assessor in any patient care areas where patient is present, you should take the consent of the patient for the assessor to be present there. Operation theatre is a key area of functioning of an eye hospital, and the assessor would like to visit the operation theatre and see it functioning. So please see that the operation theatre is functional on the day of the assessment. You should have posted some surgeries on that day also. An important area of mistake which most of us do is that we try to hide facts at times. Please do not hide facts. Be very honest and share all details, whatever are required for the assessor to know, very openly. Even if there are any legal matters which your hospital is going through, please share that with the assessor. Sooner or later, the assessor will come to know about it. The best thing is to share these details with the assessor. Few important reminders. No external person from any consulting agency should be present as part of the team. Be ready for any announcement of codes from assessor. Your rapid response teams for every code should be alerted. Note down all observations of the assessor as your quality improvement points. So the person who is accompanying the assessor should note down all these observations. And remember that assessment is a sampling exercise. So the non-compliances with this assessor has picked up, maybe they were not picked up in the past, but there is no point arguing with the assessor about it. I wish you all the very best for your assessment journey, and I hope that my talk was helpful. This is warm.
So another 3 minutes, I'll just cut short this post-assessment presentation to 3 minutes. And you can, in the meantime, prepare your questions. As long as they allow us to take questions, we are free for you. So post-assessment, what you basically get are lots of things, but the important thing is immediately you get something which is your non-conformances, right? So this is actually something like this will be given to every hospital, okay? So here there are 3 components. This is the standard against which the things were not found up to the mark or the non-conformance to that particular standard. That's why I say NC. So ROM 2G, Madam showed no, so you have to go to chapter ROM, standard number 2, element number G. So like that it will be very specific that the functioning of committees is not reviewed by the ECO for their effectiveness. Okay. Now, what you have to do is you have to make sure that you do that review, and that review will be in form of a document, in form of a structure change, whatever photo, PDF, and that has to be uploaded here saying that what changes you have done. You can say that we had a review meeting for management and this thing, and this is uploaded. Now, another thing is we were also saying that the person who's accompanying the assessor should take note. So it's a sampling exercise. Though the NC is generic, here it does not reflect which committees were picked for sample, and the functioning was not there. It would be 3, 4, 5. And then after 5 they said, okay, anyways you are not having more than 2, 3, 5, so it becomes an NC. So there you can actually check with your notes that what was the committee minutes shown. Maybe you showed the wrong minutes. Go back, do and close it. So here the closure is based on the evidence which you are going to upload. If you are not uploading that evidence, the closure will not be accepted, and you again get that submit closure again. Okay. So these NCs will be very specific. Like here, it says that there is no committee. So you have to make a committee, have an order that committee has been made. What are your members of that committee? Have some minutes of your meeting, and then you upload those things. You get 3 months time for closing this thing. So mostly hospital upload something whereby you don't know what is the closure, whether it's a deliberate thing or they really have not understood. I still fail to understand. So NC is about medical record and upload is something else. Some SOP manual will come. Whereas the NC is reading that in medical record this was a deficiency, you get an SOP manual uploaded. So where that lacuna is, I don't know, but this is very specific. And in case there is a doubt, most of the time you can check with assessor that, what was the thing, I am not clear. They will again clarify in case writing wise it's not clear. So you can actually clarify what exactly it means in case there is a doubt. Let us give benefit, English is not our mother tongue. So sometimes, we make mistakes in probably communicating, which should not happen. Still a doubt, clarify. So this has to be done on time, and this is the basis where your assessment will get closed, and you will be put up for, case will be put up for accreditation committee to final accreditation. This does not give you accreditation. After this, each and every hospital case will go in front of accreditation committee, which will take a final call. Okay, so this anyways I have told you. So what will happen is, once this closure is accepted for AC meeting, you will get a mail from NABH and they'll ask certain things in a particular format. You would have already given those things, you have to give it again in whatever format they want. Typically manpower detail, a PowerPoint about hospital, some agreement, and certain other things will come. This is because this PowerPoint will be presented before AC. And when they want further details, your old data will be referred to. Okay. And what we'll do after you get the certificate, first, after 2 years, you have to recertify. In case of accreditation, you'll have a surveillance assessment. After 3 years, you have to go for a reassessment. And continuity is important. These are the things which are on continual basis. These have to continue. It's not that we do it, get our accreditation, and then we leave them. Or the person who was doing leaves and no one else overtakes those things. So all those things, please take care that if you get NABH, please maintain these activities and make sure the NCs which were there in the first meeting are actually closed, and make sure that closure is there after 3 months or 6 months, because they were the weak areas for us. So any chapter where we are not good at, we see that we read it properly again. And most important, NABH has a timeline. So you have to reapply for your next level 6 months before it expires. Please apply 6 months before. In case you are not getting an answer, please be in touch with them, because in COVID that was not happening. So they would say, okay, we are extending for 3 months because of COVID. So you get, but from our thing, the date of certificate, whatever it is, 6 months before, please apply for this thing, and you can also write a mail to NABH and be in touch with them to make sure that, you know, it's done. Otherwise, if it's too late, there's a discontinued certificate, we only suffer more, right? Assessment is done 1 month before, the certificate will not come in time, and you are already using that for your empanelments. So this is in brief, though it was a detailed presentation. For questions, because madam wanted and everyone, please ask. So, madam, Mike, I can't hear you.
We wanted to do the NABH accreditation early, first level. So we are following the good practices since 2 years, and we have appointed some person from Mumbai. He has guided us all, and but I want to ask you one thing. We all of you, we use ILMaster 7 and everything. We have do we require AMC of every machine to be shown to NABH personnels, or what? We want to know.
Okay. So, my take on that, and madam can add, first decide what are your critical machines. Okay, any machine which is critical to patient care, you should have an AMC. Okay.
Means I'm asking about Varion, ILMaster 700, OCTs
Madam, I am answering very generically. What are the machines which are critical for your operations? So, a phaco machine, you should have an AMC, because if it's not running, your surgery will get compromised. Okay. So, whatever critical equipment you have, you divide your, all your list. Now you have your anesthesia machine, multi-para monitors, they are all critical. So there you should have an AMC. Even otherwise without anyway, that's my opinion, and that's what I look for as an assessor. Now there would be certain non-critical machine, slit lamps and your indirects. There are multiple slit lamps in a hospital. If it's only one slit lamp, then it becomes critical. But mostly, at least in our hospital, like we have 25. I don't know how many you have. You may have 4 or 5. So those things then don't become critical. So those could be just on a regular annual check for functioning, and there need not be a comprehensive maintenance. Okay, some sort of AMC will be there. No, your biomedical engineer, someone will come and service. So let's say there are 2 words, AMC, CMC. Let us not mix. So AMC, CMC will conclude that where you are having a CMC or AMC on regular basis, here you can have your service history. A slit lamp can be serviced and can be used. There is no harm. It's not a critical equipment and it does not harm a patient, unlike a phaco machine. Okay. And certain old machines, you will not get CMC. They could be on a service basis. And certain machines like laser, you will need a certificate that they are fit for human use, especially laser machine. So how your vendor is giving that certificate is also important. He may give you on a service basis, or he will say, no, without AMC, I am not giving. Particular multinationals will not give without AMC. So you have to look in those cases. But the key thing, remember, if it's a critical equipment, we want it to be in a perfect shape to be used on a patient.
What about the equipments like OCT, HFA, D-scan?
Sir, again, if you have anything multiple, like you have ILMaster A-scan, I would not consider it to be critical. Okay, but if you have only one A-scan and everything based on that, I would definitely see how you are calibrating and whether it's being serviced based on the usual requirement for that particular machine. So most of the machine, if you see, have a manufacturer guideline. Like if you take a car, it says no service at 5,000 kilometers or 1 year. That's a manufacturer guideline. Now if you don't follow that, what happens? They don't give you a warranty, or their claims are not there. Similarly, each equipment comes with certain thing. You go with a manufacturer. So if they say this service laser has to be serviced 6 months, it has to be serviced 6 months. There is no alternative to that.
How about from third-party biomedical engineers?
No issues, as long as they have kind of a certification or something, it works. No issues.
They have a certification.
Yeah, you can't just make an electrician a biomedical engineer, no? So if a firm is registered, it's a proper firm and all, it's okay.
So who has underwent a proper
That's okay with
Yeah.
anything will work there.
So there are trainings available at Arvind and all.
Yes.
So they need not be engineers, they can be technicians who can be trained. And
ITI
on day to
technicians
day,
and
yeah,
all,
yeah.
they can be trained. So for your routine activities, but specific activities, if there is a trained center which has already done, no one is really fussy about that. See, what we are looking at is patient safety. That's all.
Here the complete concept is, madam, whatever she everybody is, the moment the word NABH comes, everybody is scared. So
That's why we are saying
that
don't be
should
scared.
go.
We are
That
trying
see,
to
I
make
think
it
her
as
question
simple.
is that she's having all practice. That's the only thing. Here, if you are okay with this biomedical engineer from a certificated person, that is a very beautiful thing. No, that is what that clarity she wanted.
So one more question. We have opted for the everything is computerized. So do we need to show the OPD papers physically, or we are using OPD papers also and we have the
Madam,
computerized
EMR as per the new Digital Act, if it confirms to that and you're following the provision is accepted, you can have a paperless hospital.
Okay.
Now, again, okay, indoor becomes a gray area in terms of your consent. So, those gray areas, consent and OT notes, become a gray area where still you may like to have a physical copy kept.
So what happens if AHU fails, suddenly you are working and AHU fails?
So, you will finish the surgery what you are having and cancel off your list, and then you can do it in an alternate.
So the retina surgery going on.
No, you have to finish that case.
Sir, but if there is a draping of a patient and if he is suffocated,
अगर पेशेंट सर्जरी स्टार्ट नहीं किया है तो वहीं पे क्लोज कर दो ना यार. इफ यू आर ऑलरेडी डूइंग सर्जरी इन मिडवे यू विल हैव टू फिनिश द सर्जरी. If you put a split AC along with HEPA, it doesn't work. That will remain a pocket of infection. Your infection control will go for a toss.
split AC is not allowed as an emergency.
No, not an emergency. The very fact that you have split AC, you will not be able to have a clean chamber. You can't maintain that split AC in presence of HEPA filter.
Can we put glass for lightning in OT?
Yes,
Some people say it should not have any joints. So
glass is sealed. World-class OTs abroad also will have glass which are sealed. Not an issue with that.
anything you recommend for paint and OT or some vinyl there should be.
OT guidelines from NABH mentions paint and vinyl. Please download. I gave you the link. It's clearly mentioned there.
Sir,
Please quote that to anyone you want. to.
One more practical question, sir. For refrigeration use,
Sir, split AC, if it's inside, you will not be able to maintain that, and you have an additional thing where the bacteria will harbor. Your AHU work will also not happen. So the whole purpose is we are using AHU for better control.
Sir, what he's trying to tell is, in the presence of AHU, again you are having a split AC itself is wrong.
Yes, because you will not be able to maintain. That's what I'm saying. No. And again, opening, how will you maintain that?
Yes.
What we told split AC.
AHU, inside you cannot have a split AC, sir.
सर बहुत सारे हॉस्पिटल्स हैं जहाँ पर दोनों हैं, आपने देखा होगा, ठीक है. बट अभी क्या बोला, जैसे जैसे ऑडिट अगेन होगा ना, तो दोज थिंग्स गेट चेंज्ड. तो देयर आर सम प्लेसेस उनके पास NABH सर्टिफिकेट भी शायद होगा वेयर यू वुड हैव फाउंड स्प्लिट. They have been instructed to stick to a proper AHU system with this thing. So that thing will not be there in coming years. That's all I can say. As and when they get reassessed.
Sir, for storage in OT, can we put some almirah or that is also not allowed?
We have talked about zoning. जो आपका मेन OT है, there you have to maintain clean walls and clean floor. When you put almirah, it is difficult to maintain. So you can have a separate store zone, no? Sir, from one room to other, it is doable. We have 7 OT complex and all the things are stored in the OT store. Same for madam, 5 OTs or 6 OTs. That time, 8 OTs now, time has never been an issue.
Yeah, but we have kept small cupboards there to keep stuff.
No, sir, rakhiye. No one is saying so. What happens is, like, there are alternatives. आपको क्या करना?
Yes, trolleys. We have also kept,
Yeah.
small trolleys.
No, big trolley also, which can be moved out for cleaning. So, see, we have to understand what problem we are facing and what is the solution. So, putting a fixed cupboard inside will create a problem in cleaning, especially when you have HEPA filters.
Keep some trolleys.
Yeah, clip it, you can take them out for cleaning and you can clean the trolleys. Steel trolleys are easily cleanable. Anyways, we will have a,
Steel trolleys nowadays are available with wheels.
Yeah.
You can just,
Put-
I think, clean
so
them.
everything, at the end of the day,
Yes,
you can
yes.
actually empty out the entire OT and clean if you want to.
Sir, what about this autoclaves? Do we really need horizontal one or vertical?
Okay, I'll give a cryptic answer. Any autoclave for which you can give me a certificate that it is fit for human surgery is accepted. नहीं, कोई भी autoclave का आप एक certificate manufacturer देगा कि if this is fit for surgeries in humans
See,
or fit for
it
surgery.
was because when
No,
we
madam,
underwent.
I'll answer. मैं पहले certificate दे दो आप, जोन सा भी autoclave है accepted है. Now coming to the second part. जो vertical autoclaves हैं, उसमें वो certificate आपको नहीं देगा.
नहीं देगा.
वर्टिकल ऑटोक्लेव में कुछ मॉडल्स हैं जिसमें वैक्यूम सिस्टम है, वहाँ पर आपको मिल जाएगा. तो उसमें हमें सोल्यूशन क्या है? आपको अगर किसी मैन्युफैक्चर में कहीं डाउट है ना, उसको बोलो इसका सर्टिफिकेट है क्या, ये मैं ह्यूमन
Pre-vacuum, actually they ask for Bovidix test and all. So that is not possible in horizontal actually. That is in vertical, sorry.
नहीं, वर्टिकल में है, सिर्फ सिलेक्टेड मॉडल है, बहुत मुश्किल से ढूंढना.
बहुत ही selective
बट अगर आपको
models
मिल रहा है
हैं.
सर्टिफिकेट वर्टिकल में ह्यूमन यूज का एंड इट विल पास ऑल द टेस्ट, एक्सेप्टेबल, नो इश्यूज.
So what about this pillars in OT? Sometimes like my OT has a height of 9.5. Then I have to put a AHU also. It goes down to 1 point. The effective
नहीं नहीं पतले वाला there is a thinner one available now 1.5 में आ गया है so 9.5 1.5 you'll left with 8
Create some beams, like duct will turn like this and go and again stuck.
and I have not seen an OT can't comment but पतला जो 1.5 feet वाला भी अभी AHU solution available है
Is it not necessary to keep the whole ceiling in a one way?
without seeing OT I can't comment and the person who's buying from where you are consulting they will tell how their system works so that's a pure technical thing based on your OT someone can guide you on
As an assessor,
दिखाओ मुझे मैं बताता हूँ ना यार अब मैं verbally नहीं बता सकता what beam you are talking about
just a beam is coming and duct cannot pass. Duct has to go behind that beam.
अगर 7 फीट पे तो आप ऑपरेट कर नहीं पाओगे अगर जो भी आप कर रहे हो इफ यू आर एंडिंग अप विद 8 फीट आई थिंक सो यू विल गेट इट
That particular point, like some around corners of the OT, 3-4 feet is down, 7 feet rest and the OT is like
should be okay the way you describe but I am not 100% sure of it looks sounds okay to me
as an assessor.
sounds okay to me without seeing very difficult but जितना आप बता रहे हो it should be doable
So comment on that circulatory system. That once the patient entry gate is separate or exit gate is also should be separate.
अच्छा अभी मैंने आपको एक ना बिगनिंग में कमेंट दिया था लुक आउटसाइड आई हॉस्पिटल तो अगर आप अभी किसी अपने दोस्त के ओटी में गए हैं किसी और स्पेशलिटी में कितने डोर्स थे अदर हॉस्पिटल ऑल्सो
Yes, surgical.
ओके आप एक बार फिर से देखो NABH accredited कोई ठीक सा हॉस्पिटल जितने बड़े ओटी रहेंगे जहाँ पर यू रनिंग अदर अरे नहीं यार ओटी का ओटी में 2 डोर मिलेंगे आपको ठीक है स्टैंडर्ड ओटी डिज़ाइन इज 2 डोर्स आप एक ओटी डिज़ाइन का डालो ना बुक खोलो इतना हॉस्पिटल कंस्ट्रक्शन का बुक है डाउनलोड करो या गूगल करो हाउ टू कंस्ट्रक्ट एन ओटी हाउ टू कंस्ट्रक्ट एन हॉस्पिटल ऑफ्थेल छोड़ दो उसमें आई मत डालना you see most of the OTs will have 2 leaf door all those things which are talking and they will probably also have 2 door depending on the outer corridor design तो थोड़ा सा डिजाइनिंग इशू है ऑफ्थेल में कहीं से भी शुरू करते हैं वो एक ही है मैंने भी बचपन से एक ही देखा है so that same thing 1 door and no light that is a flaw which all of us have seen now to do that what you can do since our equipments our instruments and all are small you can put in a pass box that's what all of us are doing in OT when there is only 1 door so your pass box become a second sterile entry but if you are constructing a new OT and if you can get a 2 door and if you can make a proper system okay पुराने OT में नहीं कर सकते we'll have to find a way out so the only way out to a second door will be to instead get a pass box which can be retrofitted in most of the OTs
What is the normal protocol? The assessor is from the same specialty or some other specialty?
Sir, eye care, we try that one of the assessors should be someone from eye background. It could be there, but it is not 100% possible. In some cases, especially after COVID, when traveling and availability become an issue, you could have a team which is not related, but they'll be an NABH assessor. But if you are applying for eye care standard, typically it's an endeavor that one ophthalmologist should be part of the team. If you are going for small care and all, it will not be done. Anyone can come.
How many persons usually come?
Again, size of hospital, sir. Small hospital, 2 people will come. Big one, 3 will go.
Because I know one person is a junior colleague of mine. He got NABH certified. So no assessor came.
सर वर्चुअल असेसमेंट हुआ है कोविड के टाइम पे तो बिकॉज देवर सो मेनी एप्लीकेशन इन कोविड देयर वाज एन हाइब्रिड असेसमेंट देयर वर वर्चुअल असेसमेंट्स बट अभी तो इट्स बैक टू फिजिकल असेसमेंट अभी कल की रिपोर्ट से फिर केसेस वी डोंट नो वेदर इट गोज वर्चुअल तो वो थोड़ा सा ना 2 साल में अप्स एंड डाउन इतना हो रहा है नन ऑफ अस आर एबल टू प्रिडिक्ट हमारा भी असेसमेंट में प्रॉब्लम हुआ था वी एक्चुअली वेंट इन फॉर अ वर्चुअल असेसमेंट एंड लास्ट मोमेंट ट्रैवल ओपन देन वी हैड अ फिजिकल असेसमेंट इन वन आर अदर ब्रांच इट वाज फिजिकल गॉट कन्वर्टेड टू वर्चुअल सो वो हो रहा है नो जैसा चल रहा है गो विद द फ्लो
There are certain agencies in different cities that they claim that we will look after everything. हम लोग आपको करा देंगे ये कर देंगे तो whether to go
सर थोड़े थोड़े मैं फ़नी एग्जांपल देता हूँ जस्ट टू मेक माय पॉइंट हर बस स्टैंड एंड रेलवे स्टेशन पे इंडिया में इवन यहाँ पर भी जब आप बाहर निकलते हैं ना बहुत सारे क्लेम्स होते हैं ठीक है दे ट्रीट एवरीथिंग मेडिकल क्लेम्स होते हैं राइट तो उसमें क्या है वी यूज़ आवर ब्रेन इज इट पॉसिबल और नॉट तो सिंपल सी बात है इफ़ एनीथिंग इज़ टू गुड टू बी ट्रू इट इज़ नॉट ट्रू और अपने को अपना लगाना है अगर आपको कोई ऐसी एजेंसी बोल रही है गारंटी से पहली बात तो दे नहीं सकते बट आप उसका कोई भी एजेंसी हम पूछेंगे ना भाई तुम इतना खर्चा कर कुछ है तुमने कहाँ दूसरे हॉस्पिटल में किया क्या फीडबैक है अपन अपनी ड्यू डिलीजेंस करेंगे इफ़ यू आर सेटिस्फाइड विद दैट एजेंसी प्लीज गो हेड
So how many tables we can put in an OT?
वन
Depending on size,
इरिस्पेक्टिव ऑफ साइज
irrespective, 20 by 40. Fit.
आप यार 100 बाय 100 का ओटी बना लो टेबल एक आएगी सिर्फ और सिर्फ 2 टेबल जाएंगी ट्रांसप्लांट ओटी में किडनी ट्रांसप्लांट है कुछ है जहाँ पे अपन ट्रांसप्लांट करते हैं ना देयर द 2 tables आर देयर एक्सेप्ट फॉर दैट